I'm going to talk about two topics, okay? And the first one is whether we can diagnose Sjögren syndrome if the anti-RO antibody is negative, okay? I'm going to dive into this tricky subject. And remember that patients with Sjögren syndrome usually test positive for antibodies in about 80% of cases, or even more, okay? And this antibody positivity has been linked to greater lung involvement and Raynaud's phenomenon. In addition to anti-RO and anti-Li, which are the most specific and appear in 30-70% of cases, we can also find rheumatoid factor in about 50% of patients. And this rheumatoid factor has been associated with joint involvement, cutaneous vasculitis, and cryoglobulinemia. Anti-RO and anti-La, on the other hand, have been associated with more systemic manifestations: vasculitis, hematological abnormalities, and serological hyperactivity. Therefore, around 80% of patients will present with positive antibodies, but there will still be about 20-30% who do not have them. And these are the seronegative Sjögren syndromes with negative RO, which are characterized by more prominent dryness symptoms, autoimmune thyroiditis, fibromyalgia, and fewer lymphoproliferative complications. They may present with other antibodies, even if not anti-RO, such as rheumatoid factor, anticentromere, and a long and extensive list of other atypical ones that we usually don't test for either. In clinical practice, in clinical trials, it has been observed that there can be other antibodies. Remember that anti-RO is also part of the AIRE-MB criteria, which scores 3 points. But if we don't have that, we can evaluate using a biopsy, ocular staining, the Schirmer test, and salivary flow to try to reach the 4 points needed to help classify the patient. But here I also wanted to bring up again the usefulness of glandular ultrasound, and just with one article, which I think says it all. This article evaluates the salivary gland ultrasound score in patients, and it includes patients who are anti-RO negative. First, let's look at the first column, which represents the entire cohort, both positive and negative patients. And you can see that when the grade is greater than or equal to 2, it has high specificity and a high negative predictive value. But it also includes here, it combines a group of patients who are anti-RO negative, and you can see that it also has high specificity and a high negative predictive value. Therefore, when we say that we consider a grade of 2 or higher to be pathological, it's because of this, because it has high specificity, almost 91%. And so as key points, we can say that it has high specificity and a high negative predictive value. Therefore, in a patient with a normal ultrasound and who is anti-RO negative, we could say that the patient does not have Sjögren syndrome. It allows us to say that we can rule out the presence of this condition. This is the usefulness of ultrasound in these patients. Therefore, in conclusion, indeed, if we have a patient who is anti-RO negative, this represents about 20-30% of all such patients. They may present with other antibodies, and we can rely on other criteria to try to classify these patients. But if we don't have ultrasound available, which, as we've seen, has high specificity and a high negative predictive value, which moreover in the articles I showed, also in the previous presentation, is associated with histology, clinical findings, and serology. And it increases the performance of the 2016 ACR-EULAR criteria, even though it's not included in them. Therefore, if there are no pathological findings on ultrasound in an anti-RO negative patient, we could say that it is not compatible with having Sjögren syndrome.